Ma'am, I guess you can start now.
Okay. So before I start, I just thank Mr. Musab and his entire team, CL Gupta Eye Institute, for giving me this opportunity to present before you all. Thank you, Maitri, for the warm welcome and introduction. Thank you, everyone who have joined here. A very good evening to all. So today my topic is on pediatric eye examination. Before I start my session, I would like to quote, "Children may first These are the learning objectives from this section. So we will be seeing about how to approach a pediatric patient, history taking in pediatrics, visual milestones, step-by-step evaluation, when and what to prescribe, and the clinical pearls. So first, moving on to approaching a pediatric patient. So pediatric patient, whenever we approach them, you should be very positive, stay calm and cool, always have a smile in your face, and remember eye contact is very important, and start with a very good conversation. It's not like a regular clinic where you start with the visual complaints, chief complaints like what is your problem and all. So when a child comes, the child, you should start like asking, not a direct complaint, build a good rapport, start conversing, like addressing their color of their dress, compliment them. If they are wearing any superheroes, any cartoons, you can just compliment them, and you can say, oh, Chota Beam is your cartoon hero, or so Spider-Man, even that's, it is mine. So you can start a good rapport with them, and always try to improvise your testing part. Okay, so the approach is very, very important here. And after that, this is the subdivision of the pediatric population. So this is for your information. This is based on the developmental changes that occur from birth to childhood. So birth to 1 month is neonates, infant 1 month to 1 year, and toddler 1 to 3 years, preschool age 3 to 5 years, school age 6 to 12 years, and adolescent 13 to 18 years. Is examining pediatric population, is it challenging? Yes, of course it is challenging, but we can overcome these challenges. So there are different conditions. The children are not like adults, and most ocular problems differ from children than the adults. So each developmental level in children requires a different approach to the eye examination. So here we should have a proper preparation and attitude, so that the pediatric examination will be enjoying, and the pediatric patients will be enjoying and rewarding. So whenever a child comes to your clinic, the child will be crying. Okay, so we should not get afraid when the child cries, and you should not feel difficult to go with the examination. Always the child, we should make them feel happy and a smiling face when they go out. So we will see how do we do all the examinations in different age groups. So when a child enters the clinic, always you should do an observation. Okay, the examination begins with the observation of the child when he or she enters the room. So you should examine their visual behavior, if there is any abnormal head posture, whether the child can move inside the room happily or needs someone's help, any other dysmorphic features, ability to ambulate, and family social dynamics. So how the child is mingling with the family members. So you should observe the child first, and then comes the history. History taking is very important in the pediatric cases. It is important in all the examination, but in pediatric we do take an additional history part. So half of the diagnosis can be achieved through a history taking. So there are various steps in taking the history part. So first, dealing with the chief complaint. So you can ask about the nature and history of the presenting problem. What is their complaint, any visual complaints they have, ocular history. And in pediatric patients, you should not forget to ask about the patching they have done, if they have checked earlier and advised for patching, how long they are doing the patching, which eye they are patching, and what are the vision therapies they had advised to do. If the patching is done, what exercises the child is advised to do, and if the child is having doing any ocular massage, because that can rule out any lacrimal system disorders. Also, don't forget to ask about the family ocular and the medical history. So family history, mainly parents of history of myopia in parents, and any retinitis pigmentosa, consanguinity, you can ask here. Family history. Medications, ask for both the ocular and systemic medications the child is taking. Also, don't forget to ask any lab reports. If the child is having any CT scan or hydrocephalus is there, the brain scan is done. If previously VEP is done, so don't forget to ask any lab reports from the patient. Allergies, you should note down. Apart from this history, you should also note when the child is a school going children, you should note about the school performance. You should always record the school performance. How is the academic activities of the child? Whether the child can see the blackboard clearly, whether he or she copies the notes from the blackboard or take a help from the friend. So that is very important, academic performance. And then for the pediatric patient, birth history is very, very important. So birth history consists of three types: prenatal, perinatal, and the postnatal. Also, we take developmental history in birth type. So what is prenatal history? Prenatal is before the child born, you should ask about the mother's maternal infections and the systemic conditions of the mother. So that is very, very important here to rule out the torch. As you all know, torches, toxoplasmosis, other diseases, R for rubella, C for cytomegalovirus, and H for herpes simplex infections. So you have to rule out the maternal infections, and if the mother is having any diabetes or taking any medicines for that, you should rule out that and record it when the mother got the diabetes. So that is prenatal history. Perinatal history. Perinatal, just immediately after the birth, after the delivery, that's a very short period. So you should record the gestational age. You can ask it whether it is a preterm or a full term delivery. What is the type of delivery, whether it is a cesarean delivery, normal delivery, or forceps used, and ask for the asphyxia. Apgar score, you should record it. Apgar score is a scoring system where the child after the birth, immediately after the birth, we are noticing their activity, pulse, grimace, appearance, and respiration of the child. So it is scored in 0 to 2 points. If the activity is good, they will be scoring 2 points. So on the whole, if the child is getting the score of 7 and above, the child is normal, and they are ready to what we say, they are go out of the hospital. But if the scoring system is below 4 or 6 to 4, 4 to 6, they will be kept in observation. And if it is 0 to 3, it is severely ill, and so whatever required medications or surgeries required, they will be doing it in that scoring system. Okay, Apgar score is more important. They'll note it down immediately after the birth of the child. Next is postnatal. Postnatal is sometimes after birth until the time they visit for the examination. So you should record if there is any birth trauma or any incubation given, oxygenation is given or not. If the patient informant, like a mother or any other caretaker having the reports, you can find how many levels of oxygen are given or any phototherapy given for jaundice. So you should record all these things in the birth history. also check for their milestones, that is developmental history, gross and fine motor skills, cognitive skills. So gross skills like mostly head control, at what age the head control happened, whether the crawling happened at a correct age or not. Fine grip, like in the fine motor skills, ask about the grip the child can hold any objects, at what age the child started walking. And cognitive, mostly about the memory part. Okay, and language, speech, whether the speech is delayed or not, you should record it in the developmental history. Also check for these siblings, if the siblings have any other ocular disorders, so record it in your case file. So history taking is very important. Next, moving before to the examination, I would like to tell about the visual milestones. So this is a chart where each week, like different weeks, whatever, what are the visual functions developed, or the visual development happens. So birth to 1 week, the child starts, fixates and follows horizontally. 4 to 8 weeks, fixates and follows in all directions, also fixates or recognizes the objects. At 3 months, a child reaches to objects and also fixates on the pattern. At 4 months, accommodation is present. At 5 months, Prince grip is present. And 18 months, 6 by 6 on visual acuity cards. At 3 years, 6 by 9 to 6 by 6 on LIA or HOTV charts. And 5 to 7 years, adult level stereopsis is developed. At 10 years, the end of the critical period. Okay. So if you know all these milestones, when a child comes to your clinic to record the visual assessment, it will be very helpful when you are examining the child. So when we look at the step-by-step procedure or the step-by-step evaluation, we should start with the sensory evaluation, visual acuity assessment, refraction, motor evaluation, and the ocular health. So why I have put sensory evaluation first is, when the child comes in, you have not dissociated their eyes, or you have not asked them to close their eye to check the visual acuity. So where the fusion will not be break. So always do the sensory evaluation first, then go with the visual acuity assessment, refraction, motor evaluation, and the ocular health. So under sensory evaluation, we have two types of tests, stereopsis test and the fusion test. So this checks the two grades of binocular vision. So stereopsis, depth of perception, and fusion test is done. So in the stereopsis, we do a titmus flight test. So for a 3-year or a 2-year, we do the titmus flight test. This is testing the local stereopsis. Then for children who can identify the dots, identify the symbols and all, we will do a random dot stereogram, which tests the global stereopsis. Okay, random dot stereogram. So the normal value of stereopsis should be 40 arc seconds. Then we do the fusion test. So we all know that the fusion test is done with the help of Würth dot. We use a red-green filter and then ask the patient to see the distance target. So this Würth dot can be tested at distance and near. So distance checks the central fusion, and near Würth dot tests the peripheral fusion. Okay, and you, from this fusion test, you can know whether the child is suppressing either eye, or the child has diplopia, or fusion is present. Next is assessing the visual acuity. So the assessment of visual acuity will vary according to different age groups. So before starting with the visual acuity measurement or any other procedure, we need some basic equipment or basic tools to do the visual acuity. Is there some disturbances? We do need some basic tools like an occluder, near fixation target, pen torch, translucent occluder, and if the child is an older child, the child can read any thing. So near fixation targets, you can also use some toys or accommodative targets. Okay, so the visual acuity assessment. The slide is new. Okay. The visual acuity assessment for 0 to 1 month baby is like neonates. We do a Minas reflex test, media clarity test, and the pupillary reaction. So what is Minas reflex test? So Minas reflex is like you can identify how the baby is responding to an oncoming object here. Okay, whether the child is blinking or turning the face when the object is in front of the baby. So that is Menas reflex test. We also do this test for the malingering subjects. So you can record it as a Menas reflex present or absent. Then you can do a torchlight examination to identify whether there is any media opacities or not, and do the pupillary evaluation. Just check whether the pupils are reacting to light or not. So this is how you can do the visual acuity assessment in the neonates group. Next, moving on to the infants and toddlers. Mostly the tests are same. In infants, you can do the central steady maintain test, preferential looking test, and the visually evoked potential. So fixation preference test, where you just show the fixation preference, like you can show a target, you can occlude the eye and see which eye is the child is preferring to see the object. Sometimes the child resists occlusion on either eyes, so you can also note it, like which eye the child resists or doesn't resist any occlusion. If the child doesn't resist any occlusion, then you can come to a conclusion visual acuity in both eyes is very good. If it resists occlusion, either one of the eye, and you can find like visual acuity is less in that eye. Okay, this is a fixation preference test. And next, preferential looking test, where you can use a Cardiff acuity or you can use a Lea paddles. Preferential looking test is mainly based on the preferential looking principle, where the child prefers to look at a pattern or objects rather than a blank page. Okay, so you do a Lea paddles at any at 1 meter distance. You show different kinds of paddles here. So this is the Lea paddle test. This is the preferential looking test. So the child can see the paddles at different distances, and different types of paddles are there, like 1 CPD or 1 cycles per degree, 2 cycles per degree, 4 cycles, 8 cycles per degree. So depending on which the child has preferred looking the paddles or the patterns, you have to note it down at what meter you have done this test. Okay, and if the child is a baby or you feel some visual acuity is less, or you want to find any other ocular problem, you can check the VEP test to find the values. Next is the preschool children. When a child is going to started schooling, like KG, kindergarten, you can use the Lea symbols or HOTV charts, where they can match the objects. Or if the child wants to come again, you can always teach the parent to make them sure, like the child has to learn and come for the next visit all the symbols or the letters, so that the visual acuity testing will be easy in the next visit. So you can use the Lea symbols, HOTV cards, or the tumbling E chart for the preschool children. And for a school going children, like greater than 5 years, you can as they are older, elderly enough, and we can rely what they are saying, so we can check vision with the Snellen visual acuity chart or the Logmar visual acuity chart. And also in the Snellen, you try to give a projection chart where you project a single line, so that you can avoid the crowding phenomenon in these kids. So this is for the school going children. So on the whole, for infants and toddlers, you can do a fixation preference, preferential looking, and VEP. For preschool children, Lea symbols, HOTV and Cardiff, or the tumbling E. School children, Snellen visual acuity chart and Logmar visual acuity chart. So once the visual acuity is done, then you can go for the refraction. So determining the refractive status of the eye is very, very important. So when a child is come to determine, it is very challenging also to determine the refractive status. Sometimes child will not be cooperating, or the child will be sleeping and all. So you should understand the condition of the child, and then you have to proceed with the procedure. Okay. When a child, what you will do here, what would be the choice of refraction if the patient is less than 5 years old? So that is neonates, infants, toddlers, or a preschool children. What would be the choice of refraction? When these kids come to your clinic, they are very young kids, so we cannot rely on what they are giving, what is their subjective response, right? So we can do a cycloplegic objective refraction or a autokeratometry when required. So objective refraction we should do entirely, we depend on the objective refraction, and you can do a cycloplegic refraction here. And if you feel the cylinder power is more than 2 diopters or more cylinders are there, always try a keratometry required. Okay. So for kids, they may not sit in the autorefractometer or in the keratometer. You can always use an auto K. If the child is not cooperating for cycloplegic refraction, you can try a Mohindra retinoscopy. That is a near retinoscopy. By giving a near target, you can do the Mohindra retinoscopy. So what would be the choice of refraction if the patient is greater than 5 years old? If the patient is greater than 5 years old, they are the elderly children and we can always rely on their responses. So we can do a cycloplegic objective refraction and we can rely on their responses. So do a subjective refraction and then do the keratometry when required if the cylinder power is more. Okay. So after the refraction, you can do the motor assessment. So motor assessment, you have to do the Hirschberg test, cover test, extraocular motility test, and if required, you have to do the near point of accommodation and the near point of convergence test here. So Hirschberg test. So this is the first test you do for kids when they don't respond in the cover test or they don't read the targets. So Hirschberg test is a corneal reflex test. So you shine a torchlight and identify the reflex in the cornea. If the reflex is cornea center, then there is no deviation of the eye. Or if the reflex is nasal, temporal, or if it is up and out, depending on the reflex, you can write it, record it as esotropia, exotropia, hypertropia, and hypotropia. This is the Hirschberg corneal reflex test. If the child is not responding to any visual acuity test after Hirschberg, you can also quantify the test by using a modified Krimsky. Keep a prism on the undeviated eye and then again shine a torchlight to see the reflex. Next, you do a cover test. Cover test to find any tropia is there. So you do the cover test, cover uncover test, and the alternate cover test. So first you do a cover test, cover one eye, see the movement in the other eye, and then cover the other eye and see the movement in the opposite eye. So this is to find the tropia. Cover uncover test, cover the eye and then see the movement in the just uncovered eye to find whether any foria is present or not, and then you do the alternate cover test. You can also do the prism bar cover test by doing an alternate cover test to quantify the amount of tropia, okay, amount of the squint, that is cover test and the prism bar cover test. We also do a muscle imbalance measure test, that is we do not do in all the patients in the clinic, but in case if you feel or if you suspect any foria is there which is not identified in the cover test, then we can do this test, that is a modified Torrington method. You can do both for distance as well as the near. So distance at 3 meters and near at 40 centimeters. Hold this type of card and shine a torchlight behind the card using the patient will be wearing a Medoc straw and the patient has to report the line, where the line is. If the Medoc's line is in the center, then there is no foria. If the Medoc's line is in the right side or the left side or up or down, vertically or horizontally, depending on the direction, you have to record whether it is a crossed diplopia or uncrossed diplopia. For suppose if the patient reports at 2 prisms, then it is 2 prism esotropia. Okay, so same procedure you do for near and find the foria. After finding this doing the cover test, then you do the extraocular motility test, where you do a broad edge test to find the integrity of the extraocular muscles. Show a pen in all the 9 directions which I have put here, all the 9 directions, to see whether there is any restriction of the extraocular muscles or overaction of the extraocular muscles. Okay, for small kids and babies, it is very difficult to do. So you can do a doll's eye phenomenon. Show a doll and see whether the head and the head also moves with the doll, where they see the object, in which direction we are projecting. The child also sees that or not. Okay. The next is, if a child is an older child, complains of any headache and all, you can do a near point of accommodation and do a near point of convergence. Okay, so near point of accommodation and convergence you can be doing with the Hofstadter's RAF ruler and find the near point of accommodation, or you can use a near visual acuity target chart and give a target of N6 or N8 and ask the patient to read it, move the chart closer to the patient, and if the patient reports the first sustained blur, record that value as the near point of accommodation. So near point of accommodation you can do binocularly as well as monocularly, and find the amplitude of accommodation using the Hofstadter's formula. Near point of convergence, same, you can do it with an RAF ruler, or you can do it with a simple pen or a pencil to find whether there is any convergence or not, whether there is a convergence receded or not. Ask the patient to report the blur break and the recovery part here. Or you can do it subjective and the objective measurement. Subjective, the patient reports double, and objective, the examiner will feel where the eye has moved. That is the objective part. So this is the near point of convergence. Then comes the ocular health. So here we have completed the history part, visual acuity assessment, refraction, and the motor assessment. Then you have to assess the ocular health also. So anterior segment examination also comes here. Before that, you can also do a Bruckner test to find whether there is any ocular disorders. So Bruckner test, you can do it with a direct ophthalmoscope. You can do it at 1 meter or 3 meter distance. Shine the direct ophthalmoscope and see the reflex of the pupil. So this reflex, if there is an equal reflex in both the eyes, then it is a normal eye. And if you find any reflex like one eye is dull and one eye is brighter, or any difference in the reflexes, so if there is a brighter or lighter reflex, it may lead to, you can find that that eye has an amblyopia or the cataract. If any media opacities are there, or if leukocoria is there, white reflex, it may be like a white reflex. If it is any cataract, dull reflex. If something, any vitreous hemorrhage or blocks are there, you will have a dull reflex. So to rule out any ocular disorders, you can do the Bruckner's test also. Next, do a slit lamp evaluation to find any anterior segment disorder is there or not. So, and if a child is very young, less than 5 year or 1 year infant, you can use an handheld slit lamp to find the anterior segment disorders, and use the slit lamp for the older children to find the anterior segment disorder. So here you can check all the anterior segment part from the eyelids till the pupils. You have to check it. Then comes the intraocular pressure. So intraocular pressure is also very important. You can do a finger tension test to just check in younger kids, and to quantify the intraocular pressure, you can always use a tono pen or a GAT, Goldman applanation tonometer. And then finally a fundus evaluation will be done with the help of direct ophthalmoscope or the indirect ophthalmoscope. Okay, so once the assessment is done, so we know what is the diagnosis or what refractive error the child has, and then we have to give the management according to that. So when we come to the management part, so there are some guidelines for prescribing the spectacles in the pediatric population. So what are the spectacles we can prescribe for different refractive errors, when to prescribe or what to prescribe? So when it comes to that, first we start with the myopia. So when to prescribe and what to prescribe. If the child is 1 to 3 years of age and having a refractive error of less than -5 diopter, you need not prescribe anything. You should always monitor the child. And if there is any anisometropia, like you find a difference in both the eyes, or 2.5 diopter, more than 2.5 diopter difference in the each eye, then you have to prescribe for that child. Okay, so if the child is 1 to 3 years and if it is greater than -5 diopter, surely you have to prescribe the spectacles to the patient. And if the child is a school going children or 3 to 6 years of age, if it is less than or equal to -3 diopter, you need not prescribe. If it is greater than -3 diopter, you need to prescribe. And school going children needs full correction for distance and near to avoid any amblyopia or squint. Now myopia, because of this COVID pandemic, it has come like a myopia epidemic or myopia pandemic. Like the child is more on near work, so due to the increased near work, myopia has also come. And there are various myopia control options for the child to decide, and the consultant can also decide on what treatment we can put the child. There are different myopia control options, like pharmacological options, optical interventions, environmental modifications, and the surgery. So depending on the degree of the myopia and the child's willingness or the parents acceptance, we can prescribe the best option to the child. Under optical intervention, we can prescribe either spectacles or contact lenses, or now orthokeratology has become. And if the child is wanted to go for a pharmacological intervention, if the consultant feels he wants to put the child in a pharmacological intervention to reduce the axial length, then they can go with the atropine prescription, low dose atropine prescription. Okay, and environmental modification is required. Make the child to go outdoors and play a lot, so not to stay indoors. Child should be in outdoors. But because of this COVID pandemic, it is very difficult to make them play outdoors, at least in their balconies or in the house terrace. You have to advise them to make the child to play outdoors. Hyperopia, when to prescribe and what to prescribe for hyperopia. If the child at 1 year of age, if it is greater than or equal to 3.5 diopters, you should give a partial correction, like you can undercorrect the child by -1 diopter. If the child at 4 year of age, if the refractive error is greater than 2.5 diopter, you can undercorrect by 1 to 1.5 diopters. And if it is greater than 1.5 diopters in the school years, the child requires a full or near full correction. Okay, so if the child is having any accommodative esotropia and all, you have to give the full correction as well as the near correction for the child. Next, astigmatism at 15 months of age. If it is greater than 2.5 diopters, depending on the age, you have to give a partial correction, and every 6 months you have to monitor the child after prescribing the correction. Greater than 2 diopters at 2 years of age onwards, give a partial correction up to 3 to 4 years of age, and greater than 1.5 diopters at 4 years of age, full correction following the initial under correction. If there is an oblique astigmatism, you have to partially correct 3/4 of the astigmatism, and for the school going children, it is full correction. So always remember, whether it is myopia, hyperopia or astigmatism, when the child is going to school, you have to give the full correction. Anisometropia, when to prescribe and what to prescribe. If the child at 1 years of age, the child is having amblyopia greater than 3 diopters, you have to give the full anisometropic correction. Also correct the myopia or hyperopia according to the age. And greater than or equal to 3 diopter without amblyopia, you can undercorrect by 1 diopter, less than the interocular difference. A full anisometropic correction is required when there is a greater than 1 diopter of hyperopia or greater than 2 diopter of myopia and greater than or equal to 1.5 diopter of astigmatic anisometropia at 3.5 years of age. So after prescribing all these things, you have to constantly monitor them and call for a follow-up. If you feel their child is having myopia and the myopia is progressive, you should always have a follow up with them, monitor them. If the child has progressive myopia, please suggest them with the myopia control options. Next is the clinical pulse. So here this is very important to examine the child, and when you are practicing, so we will see the clinical pulse. Each child is different, so you cannot prescribe all the things or do the examination to all the children. So each child is different. Always you have to try to improvise your way of examination depending on the child, and allow the child to read with the abnormal head posture. If the child is reading with the abnormal head posture, don't always tell them keep your head straight, don't go close or something else. You have to allow the child to read with the abnormal head posture and find at what posture the child is comfortable, and then do the examination. If the child is having eccentric viewing, please observe that and train them according to the visual needs. Always remember to mention if the child is peeping over the glasses. So when you're checking the visual acuity, you should keep in mind the child is not peeping over the spectacles, or make sure the parents have to occlude the eye, or you occlude with an occluder, with the help of the occluder. If you ask the child to occlude, the child may not occlude properly, and the child can peep over the glasses, or the child can he can give some false statements to us. He say it is clear for me. Sometimes it will be very confusing for us to decide whether this child really need the glasses or not. Also recheck the vision with the different charts. So child easily memorizes the letters. So give some different charts and then find the measurements, fine doing the visual acuity measurements with the child. So always recheck twice. What shouldn't be missed? So what shouldn't be missed? For infants, you should not miss the delayed visual maturation, central nervous system disorder, and if any prematurity, perinatal hypoxia, hydrocephalus, and seizures disorder. You should not miss this. So delayed visual maturation is like the eyes themselves are fine, but the babies cannot connect with the cortical. The cortical connections which will allow the brain to perceive images will be underdeveloped for them. So for us, when we check, the eyes are clear, eyes are normal, visual acuity is good, but still the child cannot perceive images. Vision, he may not have a connection, cortical connections, which allow the brain to perceive the images. So that will give some behavioral responses which are underdeveloped when you check the vision. So that is delayed visual maturation. If there is a high cerebrospinal fluid pressure and all, that can damage the vision. So that will resulting in visual disorder, seizure disorder. If any nystagmus and all is there, eye jerking. So always don't miss anything in the infants. And if the child is an older children, always ask them to whether they need glasses. Sometimes children simply they will say, I want to wear glasses. Seeing from their friends, they find they fond of glasses, and they find I want to wear glasses. So they simply say, I have a headache, I cannot do my homework. So find whether the child really needs glasses or wants glasses. If there is any learning disorder in the child, any complaint of dry eyes, colored spot, or any complaint of headache. Okay. When to refer the child? If the infants are not tracking normally by 2 months of age, not recognizing the faces, recognizing objects, not tracking at any age, then you have to refer the child immediately. If you find any abnormal pupil reactions, you have to refer the child. For the older children, if there is a complaint of decrease in vision or academic performance is poor, sudden vision loss or vision loss accompanied by pain, you have to refer these kids. And always advisable every year once, yearly once, you can ask the parent to bring the child. And if you're prescribing any spectacles or any amblyopia therapy, keep a follow-up regularly to monitor the child's status. Okay, so with this I conclude, I finish my presentation. These are my references. Thanks for the patient listening. Thank you. If you have any queries, please feel free to.
There are some questions in the chat box.
Yes, yes. So can you read it?
Yeah, sure, ma'am.
Because I cannot see any chat box here.
Okay. So first question is from Manish. What is the ideal way to document history of milestone?
History of milestones. So you can write milestones. You can write in a detailed way, like a gross motor, fine motor, and the cognitive. Or otherwise, you can write milestones normal or delayed milestones. Like at what age the child started crawling, when the child started walking, when the child started talking. You can record it detailedly. If there are, if you have a column, you can record it detailedly. Otherwise, you can ask these questions and record it as milestones normal or delayed milestones. And delayed, what is delayed, you can record.
Okay, ma'am, the next question is from Himanshu. He has asked, when do we do CSM in terms of age and condition?
Yeah, CSM you can do for infants and the toddlers. Infants and toddlers, you can do the CSM where they cannot they cannot respond to the objects, right? So you can do the fixation preference test, that is the central steady maintain also. After you find the child is fixating and following the light, you do a central steady maintain, shine a torchlight, occlude one eye and see whether the child has the reflex central. Or when you occlude the eye and when you are removing it, you find the eye is not moving in, and if it is not steady, if it is not maintaining properly, if there is any squint, you can write it as uncentral, and if any nystagmus is there, it will not be steady, and if there is an alternate squint, it will be unmaintained. So you can record it as CSM for infants and toddlers. Neonates, infants and toddlers, you can. Neonates, it will be difficult, but infants and toddlers, you can always do this central steady maintain test.
From the next question is from Shoaib. He wants to ask, what is the importance of crowding phenomenon while measuring the visual acuity?
Yeah, while measuring the visual acuity to avoid the amblyopia, sometimes if there is a crowding phenomenon, if you show all the letters like a Snellen, the child may not read properly, okay? Or when you point out also, the child may feel like this letter is very easy for me, so they are pointing it correctly, I can read. So if you project and show like a line by line, you can avoid that crowding phenomenon to rule out amblyopia.
The next question is from Helen. She wants to ask if there is any anomaly regarding the accommodation and convergence. The NP and NPC test, is it enough or do we need some other test as well?
No, if there is an anomaly of accommodation or convergence, if the child is able to respond well, you have to do an other test also, do an accommodative flippers and see. But already you are doing a cover test and you are doing an extraocular motility test, you are doing a sensory and sensory evaluation. So half of the binocular vision assessment is done. So to proceed further to find what anomaly the child has, whether the convergence insufficiency is there, based on the child's complaint also you can come to a conclusion. Okay, so that's why we should take a proper history. If there is a convergence insufficiency and all, child may say headache, or after prolonged near work the child may not see the distance vision properly. Sometimes they say when they are traveling they have a vomiting sensation or nausea. So that is some clue to you when you're taking a history, and then you can proceed with the further evaluation for the accommodation and convergence insufficiency or any anomalies you want to confirm further, do a binocular vision test. So do a full cycloplegic refraction and then follow with the other test. So all these procedures have to be done with the correction.
Okay, ma'am. Next question is how to document HBT test and cover test. What is the ideal way of documentation?
I didn't get you. What test?
HBT test, Hirschberg test
Hirschberg
and cover
test.
test.
Okay, Hirschberg test and cover test. So when you want to record Hirschberg test, you can write only Hirschberg, Hirschberg test, and write whether what deviation you see. So shine a torchlight and see whether it is 7 degrees of deviation or 30 degrees of deviation. So depending on the deviation, whether it is nasal, temporal, you can write 7 degrees of ESO deviation seen, 15 degrees of exo deviation seen. Okay, and then you do a modified Krimsky test and find whether how many prisms are there, 30 prism, base up or base down, base out, like that you can write. For the cover test you should do both for distance as well as for near. So you, when you're recording, write a cover test, and then for distance, how much of phoriotropia you got, and then for the near, how much of tropia you got, whether it is an exotropia or esotropia, whether it is a hyper or hypotropia, depending on the cover test. Both for distance and near you have to do this. If the child has a good visual acuity and if any refractive correction is there with the glasses, you have to find the child has a good visual acuity, you can do this cover test. If the visual acuity is less, you can go with the Hirschberg test. So whatever test you are doing, you have to mention that test and write the values. If it is a cover test, do the prism bar cover test also, PBCT, and then quantify the amount of the squint.
Another question. In your practice, which guideline do you follow while prescribing spectacles for children?
Depending on the age and the refractive error, I will prescribe. So I have already tabled it. So that is from the article we have taken. So from the article, so I will also follow those guidelines. If the child is not wearing glasses, if the child doesn't want to wear glasses, sometimes nowadays parents have more of concerns. They want to try some alternative therapies like yoga, acupressure. I don't know. There are no much scientific evidences available. So as soon as the moment we prescribe spectacles or to the child or contact lenses to the child, the first question comes from the parent is like whether the child, my daughter or son, has to wear these glasses for a long time or it is for a lifelong. So is there any other options can I do apart from spectacles? So they would have seen many YouTube videos and all with eating healthy vegetables or doing eye exercises, the power goes down. But I'm not very sure if it is a myopia or hyperopia, whether the axial length decreases. There is no scientific evidences giving for the structural measures. Okay, all are observed on the subjectively, no objective measurements taken in those treatments. So if anybody is interested, you can always try a research on that, on alternative treatments.
Okay, ma'am. So another question is from Manish. How to do retinoscopy on patients who are having nystagmus?
It is very challenging. So when you're doing a retinoscopy or doing a visual acuity test, it is very challenging. You should not occlude the eye when you are doing a checking visual acuity for as a nystagmus patient, because while occluding it, the nystagmus, the amplitude and frequency will be more. So always try putting a higher plus, fog the eye and check the visual acuity. And when you are doing a retinoscopy, the child may not what I say, the child may not see the object properly, but try giving an object and do the retinoscopy. At least if you find some reflex, that would be better. If the child is cooperative, try doing in the autorefractometer, but it is very challenging in nystagmus patient. It comes by practice. You can do it.
And the next question is that if the child is on vision therapy, and so suppose if the child is being referred from somewhere else, what questions should we ask for our documentation?
Okay, when the child is on vision therapy, if the child is referred from other place, you know the child is doing taking or under vision therapy, you have to ask what kind of vision therapy they are doing, whether it is a software, whether they do it is on a computer based training, or they do in office, or they go to the home therapies. So what kind of therapies they are undergoing, you can ask, like matching object, coloring, drawing maze, you can ask what they do. Okay, so you can record it in that sense. And whether it is for a patching or any accommodative problem, what kind of problem they are doing the vision therapy, you can record. If the patient has any reports, please refer the reports and then record it in your case sheet.
Ma'am, the next question is pedigree chart important? When should we do the pedigree charting?
Pedigree charting is not much important with us. You can do an Apgar score, or I don't think it is much important. When there is a consanguinity and all, you can check. Or vaccination, what you're saying is pedigree is a vaccination chart?
That is not mentioned in the question.
Yeah.
Alicia, maybe
You
you
can
want to
unmute
ask?
yourself and say.
Yeah, Alicia, are you there?
Ma'am, pedigree chart is different na, and immunization that is different.
Okay, but I don't think pedigree chart is much needed here. So you can do an Apgar score. If they have an Apgar score with them, you can record it.
Okay, ma'am. Thank you.
Yeah.
Any more questions from the audience? This is a good opportunity. Ask as much
Yeah,
as you
please.
want to ask.
Pedigree chart for the consanguinity you are asking, no?
Yes, ma'am.
Okay, so if there is a consanguinity, mostly it will be done in the genetics department. If there is a retinitis pigmentosa, or you feel any consanguinity or hereditary disorders, that time you can mention whether what type of relationship they have. In that case, you can record it. But as an optometrist, we may not do a detailed pedigree chart. When we are referring the child to for counseling and all, they may do the pedigree chart. Now it's clear?
Okay, ma'am. Thank you. Yes, ma'am.
Yeah.
Ma'am, I have one question from my
Yes.
side.
Yes.
I wanted to ask in aged 1 to 3 years, if there is myopia, why we shouldn't correct it? What is the thought process behind it?
No, mostly the child will be looking at the near object only, right? 1 to 3 years. So they may not see the distance very clearly. So that time, if the refractive error is less, or sometimes if the child is a premature baby, myopia will be more. So in that case, we can observe if the child, like 6 months, that's why it is monitoring. Constant monitoring is required. So I may not say we don't prescribe at all. If the child requests, or there is a history of parental myopia, okay, so you should rule out the risk factors also, then you can prescribe based on the risk factors. Otherwise, if there is no complaints and there are no risk factors involved, if it is less than a 3-year child, the child may not find any difficulty seeing the distance. So at that time, you can wait and watch.
So, ma'am, is it possible that if we are keeping it uncorrected, the progression will be more? Is it possible?
No, still I may say wait and watch only. So when the progression will be more when they come to the school child. So whether we have to also differentiate whether it is an early onset myopia or a late onset myopia. So when they are coming to the school going, that time they may find difficulties. In that case, you may not leave the child uncorrected. You have to give the best option. Otherwise, if there is for some cases, what I say, if there is a special children, the child may not wear glasses properly. In that case, we may not prescribe if that is not helping them. If the child is a normal child, surely if you think if we leave uncorrected, or there are risk factors, some parental myopia is there, or as the age increases, cases you may find increase in myopia, you have to prescribe. That's why after 3 years you can prescribe after the constant monitoring.
Okay, ma'am. Okay, thank you so much. Any other question, audience,
other
from the
queries?
audience? Students?
Gayatri, there was one more question in the chat box.
Okay. Okay, ma'am, another question is, how much of refractive error is likely to emmetropize?
So what I say, if a child at birth, if it is a myopic or premature child, myopia will be there. So like 6 or 4 diopters you can leave. You can think for emmetropization. 4 to 6 diopters. So for my daughter, I will describe my own case. My daughter is now 10 years old, but I checked her age at 4 years. She has got like 5 diopters of hyperopia. So that time doctor has not prescribed the full correction. They have we had given a partial correction like 4 diopter, and then we have wait and watch. At 10 years now the diopter has reduced. Now she is 1 diopter. So we can wait if the power like 4 to 6 diopters, we can think for emmetropization. Less than 4 diopters.
Okay, any other questions? I hope ma'am has answered everybody's question.